Today's lecture, we're going to be talking about patients who present to the emergency room in respiratory distress and shortness of breath. Our objectives are going to be about coming up with a really organized approach to shortness of breath and breathing issues, talk about the history and physical exam to help identify the driving cause of the respiratory issue, to identify any investigations that we may need to utilize, and then certainly our treatment and disposition of the patient. Okay, so shortness of breath. So using this logarithm, in the emergency department, we're certainly going to be faced with both acute and chronic causes of shortness of breath. Specifically, we're going to be looking, focusing really on the acute, so our killers of shortness of breath, kind of like what we did with our chest pain approach. And with those acute conditions, really we need to ask ourselves, are we dealing with a cardiovascular issue or a respiratory issue? And you'll notice that a lot of the top killers can fit in both chest pain as well as shortness of breath. We're certainly not going to be talking about MI today because we covered it really well in our chest pain lecture. We're going to talk a little bit more cardiac tamponade, and certainly congestive heart failure, so those patients who are in exacerbation of heart failure, so pulmonary edema, and then our respiratory component. So are we dealing with pleural space issues, so a pneumothorax, in particular a tense pneumo? Could we be dealing with significant pneumonia? Vascular, so we're going to talk about PE, and then think about airway. So we're really going to focus on asthma exacerbations of COPD, but we also should be thinking about foreign body aspiration and anaphylaxis. We're not going to be talking about those. Those are generally kind of self-evident, and we've covered those pretty well in other lectures, courses. So really having a good understanding between a distinction between airway problems and respiratory problems can be difficult to differentiate and separate. So when we're confronted with a patient in the emerge department who is short of breath, it may be unclear whether the problem is with the airway, the lower respiratory tract, or both. So we know our ABC, so breathing comes before circulation in the approach to our resuscitation, because there's really no point in fixing the pump, so our heart, unless the pump is able to send out oxygenated blood to the tissues. So this is really kind of focusing on the B in breathing this lecture. Okay, so there are ABCs again. So we know airway. So if you have a talking patient, that's a good sign. What are we looking for? So we're looking for any kind of signs of airway obstruction, so oral angioedema, if there's any blood or vomit, could there be a foreign body? We're listening, so we're specifically listening for a noisy airway, so is it obstructed? And then think about doing, so suction, do the jaw chin thrust. Remember about C-spine precautions in any of our trauma patients. So for our breathing, we're looking for that work of breathing. Do we have nasal flaring? Are they tripoding? Do they look like they're really struggling for breath with retractions? Our respiratory rate, so are they tachypneic? And listen. So listen for those breath sounds and check. So we're checking pulse ox. And then our C, circulation. We're looking at patient's mental status. We're looking at color. Do we have mottled skin? Are they cyanotic? We're feeling. So we're feeling for peripheral pulses, and we're checking patient's heart rate and cardiac rhythm, as well as blood pressure. So our general approach to patients who are short of breath or in respiratory distress or arrest, think about those life-threatening situations. So our big killers. So pulmonary embolus, pulmonary edema. So I'm thinking about congestive heart failure patients, acute exacerbation of COPD, acute exacerbation of asthma, and our tension pneumothorax. So I like the pneumonic. Breathing poorly can cause a lot of tension, which is all of our kind of shortness of breath killers. So there is a very, very long list of causes of respiratory distress and shortness of breath. So we really need to have an approach in order to organize all of the information that we gather from our history as well as our physical exam. And then really, after considering all of the immediate life-threatening diagnosis, thinking about it from an anatomical approach can be really useful in helping to identify some of the other causes of breathing difficulty. So really having an organized approach is going to be your friend in eMERGE. So after thinking about the killers of shortness of breath, I'm taking that anatomical approach to shortness of breath. So when I think about the bronches and the bronchioles, I'm thinking about asthma and COPD exacerbations, bronchiectasis. Could I have a foreign body aspiration? When I think about the lung parenchyma, I'm thinking about like many really large categories of etiology. So whether it's blood or fluid, edema, pus infection, gastric contents, or diffusion diseases, all of those etiologies are vastly different, but ultimately they all cause the same kind of problems by either filling or blocking of the alveoli and then preventing that gas exchange from occurring. So, whether that gas exchange is not occurring because I have infection, so pus that's blocking it, or I have a patient with congestive heart failure, and that fluid overload in the lungs is preventing the gas exchange. Or I could have a patient who has gastric contents from aspiration pneumonia. That's blocking the gas exchange in the alveoli. So they all are doing the same thing, although have very different etiologies. I'm thinking about the vessels as well as the blood as well. So our emboli. So, we're very comfortable thinking about PE in association with a thromboembolus, but I could certainly have a fat embolus. So if I had a trauma patient who's had significant long bone fractures, that bone marrow is releasing the fat, I could have a fat emboli. Or I could have a pregnant patient who has a amniotic fluid emboli, or there could be an iatrogenic cause of an air emboli. Metabolic, so could I have a patient in acidosis or thyroid disease? Anemia, so really significant anemia is going to cause shortness of breath. And then any kind of issues with methylglobinemia. So we're going to talk about carbon monoxide poisoning a little bit later, but all of these things can certainly have a significant impact on shortness of breath. So next in our approach, we think about the pleural space. So I could have air in the pleural space. So we're thinking about our pneumos. I could have blood, so a hemothorax. I could have fluid, so we certainly learned about pulmonary effusion. So this isn't a disease itself. It's usually a complication from a disease, so cancer is kind of at the top of the list there. Or I could have an infection, so there could be pus there, so an empyema. The pleural space, it has very similar problems in the parenchyma, that something has accumulated in that space that's interfering with the breathing process. So once again, the usual suspects are going to be blood fluid, and pus, and unique to this specific area is air. Next, we'll kind of think about the chest wall and the diaphragm. So, do I have a trauma patient? So, flail chest, if you get to see this in the emerge department, it is not great for our patient, but actually kind of super interesting to watch what happens with the flail chest. I could have a spinal cord injury patient where they're just not able to move air because of paralysis of that diaphragm. I could have a rupture of the diaphragm. Think about some of our neurogenic causes, so Guillain-Barré or myasthenia or ALS. And then some of our congenital issues. So scoliosis was just recently talked about. So really significant scoliosis. They just don't have the capacity to expand the lungs. So when the chest wall, think about the intercostal musculature and the diaphragm as either being damaged or not functioning, and that results in that breathing impairment. So trauma, neurological disease, and congenital deformities are really all of the culprits that are associated with the chest wall and the diaphragm here. And then the last anatomical approach is really looking at cardiac issues as well as central issues. So many cardiac causes of shortness of breath cause pulmonary edema. Some cardiac diseases increase that pulmonary vasculature pressures and therefore lead to decreased lung compliance, and then therefore leading to shortness of breath. So some of the cardiac causes, so we're very familiar with MI. We're going to talk a little bit more today about cardiac tamponade, our valvular disorders, as well as the congenital heart defects that we talked about in peds. And then central, so hypoventilation. So do I have an oversedated patient? Do I have those patients who are CO2 retainers? Fever is a big one here. And then psychogenic and anxiety certainly can present to the emerge department with shortness of breath. So taking a history with patients of shortness of breath. So really kind of important questions if we can get this information from directly from our patient or patient's family or friends is having a good understanding about the onset of the shortness of breath. Is this an acute exacerbation, or is this like a chronic ongoing thing? The severity, presence of our associated symptoms, especially focus on any kind of chest pain, fever, or cough. Have they been exposed to any toxic substances, exposure to allergens? Could it be a possible foreign body ingestion or aspiration? What their past medical histories, medications, and dosages, and are they compliant with their medications? And then any risk factors, so ischemic heart disease, have they had a prior PE? Family history is going to be really important. So really important to try and ascertain, even in the sickest of our patients, some historical features of these disease processes. So past medical history is really important because many respiratory diseases like asthma and COPD have a recurrent course. So asking the questions of, particularly with pediatric patients and asthma, of like how significant and how far I'm going to step up my treatment is, have you had any past incidences of asthma exacerbation requiring hospitalization? Have you had any intubations? Those are like really critical questions to ask our patients presenting with emerge, because if it's gone that bad before, chances are this exacerbation could be heading in the same direction, and we certainly take those patients a lot more seriously. So what are we going to do with our patient in respiratory distress? So the first thing we need to do is reassure our patient. When patients are short of breath, they are extremely anxious. There is no worse feeling than not being able to catch your breath. So we just tell our patient that we've got them we are going to do our best to take care of the situation as soon as possible. Like very quickly assess their O2 sats. Don't delay giving oxygen when the sats are supporting that. Listen to the lung sounds and get your history, and certainly eyeball your patient for any signs of work of breathing. Think about some of the reversible causes. So if you have a patient who, has a history of heart failure, and they may be coughing up pink frothy sputum, or they just have really wet sounding lungs, sometimes just like hitting them with a good dose of Lasix and throwing on BiPAP or CPAP to help push out the fluid out of their alveoli and open up those air spaces is going to be a really quick reversible cause. So wheezing, so those patients who are presenting with exacerbation of either COPD or asthma, like give them that bronchodilator. If we have silent unilateral breath sounds, do a needle decompression. So if you've got the point of care ultrasound, just having a quick look and seeing if there's any lung sliding, palpating the skin around the chest and feeling for any sub-Q air, which kind of feels like Rice Krispie crackling. That's a really good sign that, throw in a needle or a finger decompression and then put in a chest tube. And then anything else, supplemental oxygen, and really kind of further working it up. The O2 sats are going to be your guiding force here. So generally, if I have a patient who's really struggling and I have O2 sats of less than 92, that's kind of the number that's in my head of, I might not be like jumping on intubating, but I'm thinking that could be where I'm heading. And so I have that kind of in the back of my mind as I'm working up other things. That being said, if I have a patient who's a known COPDer, he might be normally satting at 90, and that's his norm. So kind of beware of those CO2 retainers. And then our congestive heart failure patients of trying to go the less invasive route with BiPAP is actually more beneficial, and we don't have to think about sedating and paralyzing patients with intubation. But really important to remember, if we suspect a PE, they can present with respiratory distress with absolutely normal lung sounds. So really quick thing to do is just have a quick look at their leg. So, remove the blanket. Do we have signs of DVT? So that quick eyeballing of kind of everything, but keep that in mind, and that can help guide where we need to go there. Okay, and as far as our physical exam, so our inspection. So once we have the airway controlled, really look at the rate and pattern of the breathing, because this gives us some really important clues. So are we having a patient who is tachypneic? So that's the norm for most conditions, so both interpulmonary and extrapulmonary. Do we have a patient who is bradypneic? So really, really slow respirate. So that is a classic sign of opiate intoxication, as well as some other really, really bad CNS events. What is the pattern of the breathing? So this can really be useful for indication of any kind of a metabolic or neurogenic causes. So we talked about Cosmel when we talked about DKA, or do we have an aptic type breathing pattern? Is our patient showing signs of agitation and anxiety? This is a classic indication that our patient is really hungry for air. Again, there's no worse feeling. So patients get very, very agitated and anxious when they are needing oxygen. Are they obtunded? So this could be indication that they're either hypoxic or hypercapnic. Observe for those mechanics of breathing. So like what's going on with the chest expansion? Is it unilateral? Is it bilateral? Is there any accessory muscle use? Is there paradoxal breathing? Any indrawing? The one thing that I do if we have a patient who is able to speak is how many words can they get in a sentence, like kind of per breath. So I had a patient who didn't look like a PE type patient, but as she was speaking, it was like every second word she was having to gasp for air, versus you should be able to have a fairly normal number of words per breath, but every second word she was just gasping for air. So kind of keep an eye on that kind of pattern of breathing with how they speak. Certainly cyanosis. So we have a patient who is cyanotic. That really is kind of a late and ominous sign. Except in kind of chronic interpulmonary and intercardiac shunts, as we kind of learned about previously. Look for any surgical scars over the chest, so that can be clues to some underlying pulmonary disease or impairment or potentially cardiac issues. A key clinical pearl to remember. So hypoxemia leads to agitation. So they're the air cravers. So fix this with increasing FiO2. So whether you're using a nasal cannula, a face mask, or BiPAP. And hypercapnia, that leads to sedation. So those patients have altered mental status, they're out of it. And really fix this with increasing ventilation. So this is typically going to be intubation and mechanical ventilation. So those are really two kind of key clinical findings. So agitation, think hypoxia; sedated, altered mental status patient, think hypercapnia. So some of other physical exam findings. So when we're doing our palpitation, so that could, as I mentioned before, reveal any sub-Q air, so emphysema. So that could be a pneumomediastinum or a pneumothorax. What's the position of the trachea if it's not midline? Percussion, that certainly helps to define what it could be. So do we have a hyper resonance due to air? So think pneumothorax, or is it dull? Maybe we have a pleural effusion or a hemothorax, so blood within that space. Auscultation, so our breath sounds, any wheezing, think about the bronchospasm conditions. Is there crackles present? So do we have that wet lung? Is there a pleural frictional rub? So these clinical means are like a great way to examine patients, but sometimes in emerge and patients that come in, we may need other alternative measures of figuring out what their respiratory function is. So pulse ox is extremely important, but think about your ABGs as well as your pulmonary function tests. So we tend not to do pulmonary function testing in the emerge department, but there is some quick, easy tests that we can do that gives us that same kind of information. So I think we're all very familiar with pulse ox, so O2 sats. It's a really great, valuable bedside tool to rapidly determine oxygenation and whether it's adequate or not before our ABGs may be available. But keep in mind there are some factors that could potentially affect our pulse ox. So patients in really extreme shocky states may not be picking up. Severe anemia, patients who are hypothermic, some patients who are on vasopressors, and then some other causes. So if you have a jaundice patient, there's skin pigmentation. Nail polish is going to be not our good friend here. Our ABGs or AVB gases are going to be really important. Helps us determine, whether we're dealing with respiratory alkalosis or alkalosis. As I said before, the venous blood gas provides a pretty close approximation of what we would get with an arterial blood gas. So if you aren't necessarily needing measurements and are struggling with getting an ART line going, doing the venous blood gases gives you some important information. And then the kind of quick, easy way to do a modified pulmonary function test in the emergency department is doing our peak meter reading. And so it's a handheld peak flow meter, and that assesses the severity of the airflow limitations. And it's really helpful for patients with COPD and asthma, but our patient has to be cooperative. So if we have a patient who has altered mental status or a decreased level in consciousness, this test is not going to be very helpful because they can't help us. So other important investigations in the eMERGE when dealing with a shortness of breath or a respiratory distress, certainly our CBCs. So we're looking for any evidence of severe infection or severe anemia, looking at our electrolytes, so certainly calculating the anion gap, cardiac enzymes, so if we have a patient where we're thinking MI, D-dimer, so again, only helpful in ruling out PE, our gases, as I mentioned previously, and then chest x-ray is going to be important. So we're specifically looking for any kind of forms of lung pathology there. Okay, so let's talk about acute respiratory failure. So acute respiratory failure is defined as hypoxia, so our PO2 of less than 50, with or without associated hypercapnia. So hypercapnia is a CO2 of greater than 45. So it's divided into two types. So type 1 is respiratory failure without carbon dioxide retention. So there is a marked mismatch. Usually it's that interpulmonary shunting. So examples of this is diffuse pneumonia, pulmonary edema, or ARDS. And then we have type 2. So this is respiratory failure with an increase in PCO2. So that involves a VQ mismatch and inadequate alveolar ventilation, and that's broken down into two separate categories, A and B. So category A of type 2, those are patients that have generally normal lungs, but they have inadequate ventilation due to disorders of that respiratory control, so that respiratory drive. So those are our overdose patients, our trauma patients, if there is any CNS disease, potentially neuromuscular abnormalities such as muscular dystrophy or Guillain-Barré myasthenia, and then any kind of chest wall trauma. And then type B, so those are patients with some kind of an intrinsic lung disease as well as the VQ mismatch and alveoli hypoventilation. So these are patients in respiratory failure that's caused by an additional clinical insult. So think about infection, which tends to worsen the disease. So if you have a patient who has chronic COPD that is now infected and having pneumonia, so we're going to have a COPD exacerbation because of the pneumonia. So there is some kind of an intrinsic lung disease that's making this mismatch much worse. So what are some of our indications for intubation? So think about airway protection. So those patients who have a decreased level of consciousness, we want to prevent any risk of aspiration, local compression. So do I have a trauma patient that may have an expanding hematoma or a potential abscess? So that being said, that airway protection is really important, but do I have a patient who I can somehow quickly change their level of consciousness? So I'm thinking about those patients who may present with, major altered mental status changes in a hypoglycemic patient. But as soon as I give them a little bit of sugar, that they snap right back. So that patient, even though they have an extreme decreased level of consciousness, I can quickly reverse that based on immediate treatment, versus a patient who may have a long ongoing issue. Protecting that aorta is going to be really important. Do I have a patient that has a need for positive pressure ventilation? So I could have an obtunded patient who has a decreased respiratory effort, a patient who's in respiratory failure, which we kind of previously described on the last slide. Hypoventilation. So do I have a patient who's got, PCO2 of more than 60? Do I have a patient who has been involved in some kind of a local trauma and has inadequate ventilation? So flailed chest. So if you've never seen what a flailed chest looks like click on this link. It's kind of really interesting to see. Do I have a patient who's had a pulmonary contusion? So seatbelt from a car accident is a common cause of that. Is the ventilatory requirement exceeding our respiratory capacity? So do I have a patient who is in severe hypovolemia? Do I have a patient who's in septic shock? And then prophylaxisly. So do I have a patient who has a potential for airway or ventilation compromise? And specifically, I'm thinking about transport of a critically ill patient. So it's really better to be proactive and establish an airway prior to getting a patient in ambulance or on a helicopter transporting them somewhere else. So really important to be proactive in protecting those patients' airways. So we'll quickly get through this slide. So oxygen-specific treatment. So, we certainly know nasal prongs and face mask, our oxygen reservoir mask, our bag valve masks, CPAP and BiPAP. I know I have talked about that. So BiPAP is going to be your friend. Anytime I had a patient in congestive heart failure that was having, pulmonary edema, hit them with a big dose of Lasix and throw on the BiPAP before I would intubate, because sometimes the BiPAP is enough to prevent needing intubation. So again, that BiPAP is going to push the fluid out of the alveoli and really open up that airway. Other modalities, think about needle decompression and chest tubes for our pneumo patient. So clinical PEARL really is in severely short of breath patients and hypoxic patients who you think you can treat the underlying problem without resorting to intubation, and ventilation, go ahead and do that. So if you have a heart failure patient, using those diuretics and afterload reducers can help prevent intubation. So when you intubate a patient, you're going to have to sedate them and paralyze them, and that comes with another slew of problems. So if you can treat the underlying condition quickly enough and avoid intubation, that's really your plan. And here we just have a a picture kind of outlining the differences between CPAP and BiPAP. A lot of ICUs and Emerge are trying to use this as first line if they can, to avoid intubation. So let's specifically talk about some of our major issues of shortness of breath and respiratory distress. So asthma exacerbation. So this is such a common thing that you will see for sure when you work in and do your clinic time in Emerge department. So I'm not going to specifically go through all of the asthma etiology and pathophys. If you're struggling with this concept, I would go back and review whether it is your respiratory slides or watching osmosis videos. It is going to be a really critical piece. Writing the PANTS is having a good understanding about what's the behind the scenes of asthma. So asthma exacerbation is when patients are having an active asthma flare. So it's typically characterized by cough and chest tightness, shortness of breath, and wheezing. Airway obstruction is not specific to asthma. Therefore, taking a really good history and physical exam is important in order to exclude some of the other diagnoses. Key features of asthma diagnosis is like understanding the nature and the time course of the symptoms, knowing any precipitating triggers of the patient, use of medications prior to arrival. So how often were they taking their rescue inhaler? And then any high-risk historical features, as I mentioned before. I really want to know if they've had any previous hospitalizations from asthma exacerbations and whether there was any previous intubations. Going to be really critical. Physical exam, so what are we looking for? Do we have an anxious or a drowsy patient? Are they unable to speak in full sentences? Do we see use of accessory muscle use? So that's a significant risk of a rapid decompensation. And then any worrisome features. So are there signs of central cyanosis? Hypoxia, so our SATs less than 90? Is there significant tachypnea or tachycardia? Is there pulsus paradoxus, diaphoresis, diffuse or absent wheezing, poor air entry? Physical exam findings not sensitive indicators of severe exacerbation. So one of the docs, when I did my training, said the two things that patients present to the Emerge department with that still scared him to this day, and he'd been working in Emerge for about 30 years. MI's not a big deal. Cardiac arrest could handle it. But kids that came in with, my dog, asthma exacerbation or anaphylaxis are the two that still scared him to that day, because these patients, when they go downhill really fast. I can speak from my own anaphylaxis experience, and I have worked with a number of patients in asthma exacerbation. It is no joke. So formal diagnosis of asthma, we all know we do spirometry. 75% of patients will have this diagnosis by the age of 7. Prior to about 6 years of age, we tend to call it reactive airway disease, because they have to actually do the pulmonary function test to make the official diagnosis of asthma. If anybody has ever done any kind of pulmonary function test, it is not easy or pleasant to have to go through. So kids really struggle with pulmonary function testing. So what are some of the triggers? So allergen exposures, infection, so viral infections, exercise, cold air, emotional distress. GERD is also a trigger. What's our high risk? So I mentioned the prior intubations, prior hospitalizations or ICU stays. frequency of our albuterol use of inhaled or oral corticosteroids at home, the frequency, so how often are they having emerge visits from their exacerbation, any comorbid conditions with these patients. So do they have COPD on top of asthma? Do we have coronary artery disease? So severe asthma is defined as the VEF1 of less than 50% of the predicted, so typically less than 200 per minute in an adult, or generally it's one's own best kind of personal measurement. So symptoms of asthma severity. So I kind of like to think about it as, do I have a patient who's kind of near death, severe, and then kind of moderate? We're not going to be talking about mild asthma. So near death exacerbation, so you're going to have an exhausted, confused, cyanotic, diaphoretic patient. There'll be a silent chest, ineffective respiratory effort, and failing heart rate. And O2 sats are generally less than 90. In severe, patients are like hunger, agitated for air, diaphoretic. They'll be labored respirations. They'll have difficulty speaking. They're not getting any relief from our beta agonists. Sats are less than 90%. This is the time we really need to think about doing an AVG, as well as using a non-invasive positive airway ventilation, so our BiPAP and CPAP. Moderate severity, so they'll be short of breath at rest. They'll have cough, congested chest tightness, nocturnal symptoms. They're not getting their relief from their beta agonist. And their predicted value is 40 to 60% of either their previous or what is predicted. So our diagnosis, so routine investigations are not necessarily required in uncomplicated asthma, but these are the investigations that we can do in eMERGE. So our CBC, again, looking for anemia, signs of infection, basic metabolic panel. Our ABGs are going to be really important. Chest x-ray. So why would I do a chest x-ray in an asthmatic? So if I'm thinking about, potentially pneumonia, or ruling out any other comorbidities, or looking for any kind of an alternative diagnosis, EKG, again, I'm looking for any comorbidities or an alternative diagnosis here. So our initial priorities in the management of asthma exacerbation. So again, our first approach is always going to be our ABCs. So again, if they're talking, that's a good sign. Really basing it on our presentation. So do we need to be thinking about immediate protection of the airway? If that is the case, we need to be thinking about the rapid sequence intubation, getting them on a cardiac monitor, establishing IV access. So that's generally 2 large bore IVs or 1 large bore IV, and either an ART line or a central line, and then getting them on a continuous pulse ox. So regardless of the etiology, airway and breathing are going to be your most important initial concerns in any patient. Once we've got these under control, then we need to think about circulation, and then our Ds and Es as well. Our standard treatments for asthma, so our adrenergic agonists, our anticholinergic agents, and our corticosteroids. So MAG sulfate is often given to patients with severe asthma exacerbations. There tends to be no good benefit of MAG in mild to moderate asthma, but MAG seems to benefit patients with severe airway obstruction. So the kind of thought here is it's thought to compete with calcium for entrance into the smooth muscle therefore inhibiting the release of calcium to prevent acetylcholine release and inhibit mast cell release of histamine. So it may also inhibit smooth muscle contraction. That is somewhat controversial, and it's certainly contraindicated in patients with renal failure. And our patients for the near-death asthma exacerbation. So getting them on O2, cardiac monitoring, pulse ox, IV access, doing our intubation rapid sequence, continuously giving beta agonists and anticholinergic agents by nebulizer or a metered dose, plus an endotracheal tube adapter, IV corticosteroids, magnesium in this case, getting that post-intubation chest x-ray. So we want to rule out for a pneumo as well as check for tube placements, getting ABGs, and then think about the post-intubation maintaining paralysis and keeping them sedated. Consider alternative drugs such as IV beta agonist and inhaled anesthetic agents as well. So our treatment for severe and moderate asthma. So with severe, again, they're getting oxygen, cardiac monitoring, pulse ox, IV access. This is the time to be anticipating for the need for intubation, constantly monitoring any signs of clinical improvement or worsening. Other aspects are similar to near-death asthma management, so our bronchodilators by neb, and then our moderate asthma. So they're getting oxygen and beta agonists, systemic corticosteroids, anticholinergics can be helpful if they're not responding appropriately to our beta agonist, and then kind of evaluate our treatment is going to be important. So the question we need to ask ourselves is to admit or not to admit. That's kind of always the question. So consider discharge if and only if our patient is responding really well to the therapy and we're using subjective and objective criteria. So are our symptoms resolved and staying resolved? Do we have a normal or as close to normal pulmonary exam as we can get? Are they on room air and kind of moving around the emerge department? Do we have an improvement of our peak flow to greater than 70% of predicted or within 70% of their personal best? So if discharged patients really need to go home with albuterol, our space device, and then a 5 to 7 day course of steroids, and they really should be followed up with their primary care physician, PA. Although inhaled corticosteroids are not considered effective in treating acute asthma exacerbations, they really are kind of the mainstay treatment in preventing those exacerbations. So having really good patient education is going to be really important. We need to consider admission when our patients are failing to respond to therapy after 4 to 6 hours, and or if they're having partial response to therapy, and one of the following. So, do we have a new asthmatic? We don't really know what their story is or how they respond. Do we have a history of patients who've had multiple prior hospitalizations or ER visits or post-intubations, I'll add? Do they have a comorbidity such as coronary artery disease? Do they have significant medical or social issues that may impair them from getting health care? So whether it's access, they just don't have personal judgment, severity of their symptoms, or kind of a good understanding of their illness disease process. clinical pearls for our asthma exacerbation. So initiate therapy with albuterol and oxygen before we've done a history and physical exam. We want to keep our patients comfortable and get treatment started before we start asking them history questions and doing our physical exam. Corticosteroids should be administered early, and they should continue for a week after discharge. Measure that peak flow to not only help assess the severity, but how they're responding to our therapy. Most asthmatics should be discharged from the ED with inhaled corticosteroid to prevent more exacerbations from occurring. And then consider those patients who present with initial wheezing, may have other etiologies such as foreign body, pneumonia, congestive heart failure, and really the big one really should be the star highlight of the young female who has just started birth control pills, who is wheezing, and it's just kind of assumed, even if she has a history of asthma, that she's having an exacerbation. That kind of a patient, or a middle-aged female who's just started on hormone replacement therapy, it is PE until ruled out. So keep PE in your differential diagnosis for sure. And then the absence of wheezing, really important to understand this as well, is it sometimes can be very misleading in our patients. Those patients who are near death in asthma exacerbations, they're not wheezing because they have very limited air movement. They're just not moving air. So don't let that throw you as well. Our clinical pearl for acute asthma. So consider oxygen, our Ventolin, Atrovin, our steroids, magnesium, so in severe and near death, ketamine for our intubation, our positive pressure, and then intubation. So patients are at risk for relapse. So who are those patients? So previous near-death episodes, frequent ER visits, frequent hospitalization, if they're dependent on steroids or frequent use, if they've had flash attacks, prolonged duration or recent exacerbation, if medication compliance is poor or they have a poor understanding of self-management, if there is a prolonged high dose use of beta agonists as well. Okay, moving from asthma to COPD exacerbation. So as we remember, COPD is progressive, largely irreversible airflow obstruction. So it's due to loss of elastic recoil, increased airway resistance. This includes emphysema as well as chronic bronchitis. So common kind of patient presentation is somebody that's greater than 55 with a significant history of smoking. Or if you have a younger patient, you should always kind of keep alpha-1 antitrypsin deficiency in the back of your mind. So I know we always kind of lump emphysema and chronic bronchitis into COPD, and we think of COPD. I like to think of them separately because they look very different, and their pathophys is also very different. So emphysema, so we all kind of think of that, the pink puffer versus the blue bloater. So the pink puffer of emphysema, they have permanent enlargement of the alveoli with no kind of obvious fibrosis that's going on. So etiology here is smoking. So the pathophysiology, so we have chronic inflammation, we have a decrease in protective enzymes, and an increase in those damaging enzymes. So an example of that is elastin that's released from macrophages as well as neutrophils. And that causes alveoli capillary destruction and then alveoli wall destruction. So we have a loss of elastic recoil, and then that leads to airway collapse. So expiration is that active process and increased compliance, and so that leads to airway obstruction as well as airway trapping. Now, our chronic bronchitis, so those patients are going to present with productive cough for at least 3 months a year for 2 consecutive years. So etiology, again, this is going to be smoking. Our pathophys here is going to be chronic inflammation, but this leads to mucus gland hyperplasia. So we'll have goblet cell mucus production. Our cilia is dysfunctional, and infiltration of neutrophils and CD8 T cells. That causes an increased susceptibility to infection. So specifically strep pneumo and H. influenzae, these patients are susceptible to those infections. So COPD clinical presentation. So emphysema, so shortness of breath is going to be the hallmark of these patients. They're going to have chronic cough, may or may not have sputum. On physical exam, they'll have hyperinflation, decreased breath sounds. They'll have that barrel chest, hyperresonant to percussion. They'll be wheezing. They're kind of the skinny looking guys who are non-cyanotic, so our pink puffers. So those emphysema patients that have significant severe disease, we may see pursed lip expiration. So what does that do? So an increased airway pressure, and that prevents airway collapse. They will also be tripoding, so that kind of sitting, leaning forward, and that helps to kind of improve their breathing as well. Our chronic bronchitis patients, so they will also have a chronic cough, and this will always have increased sputum production, and they will also be short of breath. They may have a prolonged expiration. On physical exam, so we'll hear crackles and rails, rhonchi, wheezing. There may be signs of cor pulmonale, so hepatomegaly, JVD, and peripheral edema. There'll be signs of cyanosis and potentially obesity, and those are our blue bloaters. Here's some other symptoms of COP exacerbation. So cardiac, chest tightness, tachycardia. Pulmonary, we kind of talked about all of those. Systemic, they may have fever and malaise. MSK, decreased exercise tolerance. And then psychiatric, so there may be depression and insomnia involved. So we know the etiology is all about that tobacco smoke, air pollution, infection. Those are all exacerbators of patients with COPD. Most identifiable cause is going to be infection and air pollution that's driving these patients to have COPD exacerbations. Our investigations are going to be very similar to asthma exacerbation, so really important to get O2 sats and vitals, a good history and physical exam, CBC, BMP, ABG, so really important to kind of determine the degree of hypercapnia and assess whether there is decreasing deterioration in order to determine whether we need to intubate these patients. So remember, these are CO2 retainers, so they may be living very normally at 90% SAT, so keep that in mind. Chest x-ray, so certainly looking for signs of pneumonia or any comorbid or alternative diagnoses. And then EKG, again, we're looking for any comorbid conditions or alternative diagnoses. So management of COPD exacerbation. So again, we need to ask ourselves whether we're going to admit these patients or not. So consider admitting patients who are, showing signs and symptoms of respiratory distress or even are at risk of respiratory distress. So treatment is going to involve our, regular treatment modalities, so regular doses of our rescue inhaler, anticholinergic agents, continuous oxygen supplementation. So we want to try and keep the SATs above 90. Antibiotics, so half of all COPD patients with exacerbations have really high levels of bacteria in their lower airways, so they're just like pneumonia prone. Systemic corticosteroids, think about our non-invasive positive pressure ventilation, so our CPAP and our BiPAP, and then we may need to intubate patients. So intubation should be considered if we have a patient who has worsening acidosis, is hypoxemic, confused, or continues to have significant hypercapnia despite the non-invasive positive pressure ventilation of the CPAP or BiPAP. So historically, the number of COP exacerbations for patients per year is about 1.3. 50% of these exacerbations are not reported to physicians, suggesting that some of these exacerbations are going to be mild. The risk of death increased with the development of respiratory acidosis if there's a presence of significant comorbidities and if there is a need for any kind of ventilatory support. Inpatient mortality rates for COP exacerbations is about 3 to 4%, and patients admitted to the ICU have a 43 to 46% risk of death within 1 year of that hospitalization. So pretty significant. Admission of or administration of systemic corticosteroids early in exacerbation really helps decrease the need for hospitalization. So again, the question is to admit or to discharge. So biggest factors here requiring admission, like what was the severity of the patient's presentation? Do we have improvement with the medications? Is the patient still in respiratory distress? Do they have a new oxygen requirement, meaning they weren't requiring oxygen at home and now they're requiring 2 liters per minute? Or was the patient on home oxygen therapy, was previously on 2 liters per minute and now has moved up and is requiring a face mask? So there's no exact guidelines to follow. It's really about using your clinical judgment about how that patient is going to be able to cope in really the most cases. So there should be a lower threshold for admission with those patients with pneumonia as well as other kind of comorbid illnesses. So for example, if you have a diabetic patient or a patient with heart failure or coronary artery disease, or even a patient who is an alcoholic, would all be more reason to admit the patient. Our clinical pearls for COPD exacerbation. So most patients with exacerbation of COPD will require oxygen supplementation during that exacerbation. Our inhaled short-acting beta agonists are really the cornerstone of our drug therapy for exacerbations. Use antibiotics that have exacerbations and are having purulent sputum. Get those corticosteroids in early, and then consider the ventilatory assistance. So hopefully we can get away with BiPAP or CPAP, but they may need intubation and ventilation. Our clinical pearls: oxygen, bronchodilators, corticosteroids, antibiotics, ventilation, intubation. So over the last 15 years, there's been quite a sharp increase in the use of the non-invasive BiPAP, CPAP for severe exacerbations. Using BiPAP or CPAP really does significantly reduce the risks of intubation as well as inpatient mortality, especially those that have respiratory acidosis. So you will probably see BiPAP and CPAP being used more frequently than previously. Next condition of shortness of breath. So our community-acquired pneumonia. So we won't really have to go into too much detail here. I think you guys have pneumonia down pretty well. So etiology, so it's typically going to be our strep, pneumo, but also think about Haemophilus influenza, our Klebsiella, Staph aureus, and then our atypical, so our walking pneumonia being the mycoplasma. Legionella, think about that for air conditioning units and water related. Typical presentation is going to be the fever and productive cough, pleuritic chest pain, shortness of breath, rigors, specifically with strep pneumo, think about the rust-colored sputum. And then those atypical pneumonias are kind of have the more low-grade fever. They may have a dry, non-productive cough, but specifically they'll have the extrapulmonary symptoms. So our pneumonia patients in the emerge department, so they're presenting with cough, fever, malaise, rales, rhonchi, and may have positive sputum production. So our first steps, again, it's going to be our ABCs, our physical exam. So our patient may be tachypneic, tachycardic from the fever. They could be hypoxic. If consolidation is present, you may find increased tactile fremitus, bronchial breath sounds, and our crackles, rhonchi, and rales. If pulmonary effusion is present, which is actually very common with significant strep pneumonia, we'll have a decreased tactile fremitus and dullness to percussion. So our first step is going to be our ABCs. Investigation is our chest x-ray. So typical pathogens, you're going to have the lobular consolidation, atypical. Lobular is uncommon. You're probably going to see more diffuse infiltrates there, and atelectasis. CBC, so you'll have a white count with left shift. We can do a sputum analysis, although I don't really think it's very helpful because of the amount of normoflora that is going to be present. Our pulse ox and ABG, if that. So our pneumonia patient is going to be really based on whether we're dealing with inpatient or outpatient. So community acquired outpatient, like think about doxy or respiratory fluoroquinolone. So levofloxacin was kind of a go-to. Community acquired inpatient, so we consider whether we have an ICU or a non-ICU admitted patient. So ceftriaxone and azithromycin in our non-ICU. And then in our hospital acquired or ICU that are admitted for community acquired, like we're going more of a kind of big guns with Vanco and Pip-Tazo. So back in the day, we used to give a lot of azithromycin, but it tends to have poor coverage for strep pneumo. I like the pneumonic Respiratory, so lungs get medicine to kind of help remember those ones. And then don't forget about your viral pneumonia, so don't forget about COVID. So unlike bacterial pneumonia, what you'll find here is diffuse findings on the lung exam, as well as chest x-ray, so crackles and wheezing and atelectasis, as well as hyperinflation. So the interesting thing with COVID is, back when it was really, really significant, patients were actually presenting to the emerge department in florid ARDS, whereas you never really saw ARDS until patients were really significantly ill and heading into ICU. Most patients with viral or bacterial pneumonia would kind of present to the emerge department, certainly being really sick, but not in complete respiratory failure and unable to breathe. So it was a little shocking, seeing some of these patients' x-rays in the early days of COVID, how quickly they went from, breathing fairly decently into full-blown ARDS with just complete whiteout of the lung. So again, the other question we have to ask is, when do I admit patients who have pneumonia? So it's really about using your clinical judgment, and CURB 65 is really there to kind of help you make that determination. So providing a point for all of these. So is there confusion? What do we have a high urea? Respirate greater than 30? What's their blood pressure? And then age greater than 60. So those patients who have a CURB score of 3 to 5, really important to admit those patients. Those that are kind of in the middle there at 2, probable admission versus close outpatient management. So those are always the tricky questions to ask, and I would make the determination on, do they have somebody at home? Are they, responsible? And do you trust that they're going to come in when they get into trouble? Those patients who, I don't know if they're necessarily going to come back. Are they going to be compliant with medication? Are they going to come back for follow-up the next day? I'm probably going to lean more towards admitting those patients than just, seeing them go. And it wouldn't be lungs without talking empyema and lung abscess. So empyema, think about the pleural effusion of pus. So it's a complication from pneumonia. Most often it's bacterial complication. So these are rarely drained in the emerge department and generally managed by your respirologist. So typically it doesn't cause hemodynamic compromise. If it does, this one needs one of the big monster chest tubes, because pus will plug up a little guy in no time. So they need a big chest tube to drain that pus. Lung abscess, so it is kind of on the spectrum from, symptoms of pneumonia through empyema and then to lung abscess. So it is this progression. Generally, it's associated with fairly heavy alcohol use and then aspiration pneumonia. And unfortunately, these are most often anaerobes that are getting aspirated. And these are drained in interventional radiology or by anesthesia or by a respirologist with the endobronchial approach. Moving on to PE. So I think we're pretty good with PE, have a really good understanding. So we know it's the obstruction of pulmonary blood flow, most often due to a thromboembolus from a DVT, which is the most common. But if you have a trauma patient, think about fat embolus. If you've had fractures of the long bone, so any leaking of that bone marrow, high fat, that can cause blockage as well, or pregnancy amniotic fluid, or air embolism from iatrogenic exposure. So star highlight is always remember Vitro's triad. So endothelial damage, stasis, and hypercoagulable states. Signs and symptoms, so the classic triad there is we'll have a sudden onset of shortness of breath, pleuritic chest pain, and hemoptysis. Although the hemoptysis, I'm going to say, is a little more rare, but they always talk about that as the triad. Patients may or may not have cough as well. Be really careful with these patients because they could have a normal chest exam. Always good practice to have a look at patients' legs, so that exposure piece is going to be really important. That can help steer you in the right direction of the cause of shortness of breath. So physical exam could be tachypneic, tachycardic, positive Holman sign, and then look for those signs of DVT if they are present. And lung exam here is usually normal. If it's a massive PE, you could have a patient presenting with syncopal episodes, altered mental status. They could be hypotensive, or they may be presenting in PEA. So that is a common finding in a patient who has a massive pulmonary embolism. So investigations for PE, so we have our D-dimer, CBC, BMP, BNP, think about COVID and flu, ABGs. So initially, patients with PE, if it's significant, will have respiratory alkalosis, and that's secondary to the hyperventilation, and then hypoxia, and that may progress to respiratory acidosis later on. Chest x-ray, usually normal. You may have atelectasis, and then in all of the test questions, it talks about Westermarck's sign and Hampton's hump. In realistic terms, like, you're not going to see that, but it's always test questions. EKG, they always talk about the S1, Q3, T3 pattern and T-wave inversions in leads 1 to 3. In reality, you probably will never come across the S1, Q3, T3 pattern, but it is always a test question. So identifying this and definitive diagnosis is about that spiral CT angio. And that is really the confirmatory test, the best initial test. What can we do in the emerge department? So, you can certainly throw on a Doppler, do bedside ultrasound as well. For those patients that can't go in and have the CT for, you could be dealing with a kid or a pregnant patient, you can do a VQ scan in those patients. Back in the day, so we're still calling the pulmonary angio our gold standard, but it's usually not performed because it's invasive, and we can get really great information from the spiral CT. So we notice on physical exam unilateral calf swelling, warmth and redness. So our diagnosis is our DVT. That really leads us there. So here is an example of the red circle of the massive PE on our CTA. So it shows a large filling deficit in the main left pulmonary artery that is consistent with like a massive PE. So there is certainly criteria to help us make these determinations on, who we're thinking we're going to do workups on versus kind of ruling out. So modified Wells criteria, as well as PERC rule. I've always seen everyone using the modified Wells criteria. That is generally always a test question on PANTS, is the modified Wells criteria. So our PE clinical pearls, so use the criteria to help make decisions. Typical presentation is going to be chest pain, shortness of breath, which will have clear lung sounds, tachycardia, hypoxia. Our thoughts on our D-dimer. We don't need to say it again. Diagnosis is going to be confirmed with the CTA. treatment. So really support the patient's oxygenation. Getting anticoagulants started is going to be really important. So typically using an oxyperidone sub-Q. If it's massive, give them a heparin infusion and admit to ICU. They may need an embolectomy. If evidence of decompensation or cardiac arrest or cardiac collapse, we're giving our TPA. And then really what's important is, like, don't forget to send your patients home on long-term anticoagulant therapy. So I like my approach of how am I going to initially treat this PE and DVT, and then long-term, how am I going to prevent these patients from developing further clots. If I have a patient who is, has poor renal function, or a pregnant patient, getting that VQ scan as opposed to CT is going to be important. Don't forget about your Vitro's triad of our endothelial damage, stasis, and hypercoagulability states. And then our pneumos in our emerge department. I actually kind of miss putting in chest tubes. So there's 3 types we need to be thinking about. Spontaneous, so think about no underlying lung pathology. So the stem and patient is always going to be that thin, tall, skinny male. Smokers as well for their primary spontaneous. And then secondary, think about underlying lung pathology. So there's no trauma, but think about COPD with ruptured bleb. Trauma, atrogenic, so, the central line placements, biopsies, CPR can also do it. So my cardiac surgeons and anesthesiologists used to always argue on who caused the pneumo. I kind of say it was always the anesthesiologist putting in central line. It's just so common to have pneumos with central line placement. Other trauma, so motor vehicle accident, any kind of trauma. So think about rib fractures, puncturing lungs, any introduction of air in the space with trauma. And then our tension pneumo. So the tension pneumo causes the lung, heart, trachea, and vessels all to be pushed to the contralateral side because of the positive air pressure. So there you're going to see, deviated trachea. This is an urgent emergency. So you need to do needle decompression with tension pneumos right away. The others, you have a little bit of time. Really small pneumos, you can kind of watch and do serial chest x-rays. But if you have a patient that's coming in significant respiratory distress, and you're pretty convinced you're dealing with a pneumo, whether they have, unilateral chest rise or sub-Q air, and you don't have time, or, they're tied up doing chest x-ray somewhere else, is not a big deal to throw in a needle and do the decompression. Or you can pull out your pocket ultrasound and look for any kind of lung sliding. If you don't see the lung sliding, you got a pneumo, and it's a really simple, quick way to relieve that. So what are we doing with the pneumo? So if you're suspecting a pneumo and your patient is stable, then get the chest x-ray. If you suspect a pneumo and your patient is not stable, so any late findings, and what are late findings? So late findings are absent breath sounds, hypoxia. You're going to be doing that needle decompression or a finger thoracotomy, and then get the chest x-ray. And then you have to put in a definitive chest tube. Our pneumo workup. So initial test of choice is going to be our chest x-ray. Definitive test of choice that can pick up even really small pneumos is a chest CT. Do you need to do that? No. But if you're doing a chest CT for another reason, sometimes you can pick up those small pneumos that you can't necessarily see on chest x-rays, because some pneumos are a little sneaky and like to hide kind of under ribs, making identification a little difficult. But you can also use your bedside ultrasound and look for that lung sliding. So good example of a pneumo here. So specifically what you're looking for is that pleural white line. My patients tended to have kind of the smaller pneumos, so I always start at the first rib and kind of work my way down to find that pleural line. So treatment, so after we've done the needle decompression, if you have a tension pneumo, my patients, I would just kind of go right to the pigtail. So a small pneumo, they're getting a pigtail catheter. If it's a really large pneumo, or you could potentially have a risk of a hemothorax, so a trauma patient that's bleeding into the space, or some of my patients that had the open heart surgery, those need large bore chest tubes. If it is urgent, you have a non-stable, you're doing that needle or finger thoracotomy and following up with a chest tube, generally a pigtail. And then again, if it's small, just observe it and see kind of what happens. Sometimes these self-resolve, but remember to take serial chest x-rays to really keep a good eye on whether it is enlarging or resolving on its own. So this is what the chambers look like in order to kind of keep the air from going back in to the chest tube. So it's a pressure gradient. And another good example of a tension pneumo, so there is absolutely no lung there. It's pushing on the contralateral side, so certainly is going to have significant impact on how the heart is able to pump. So this is a medical emergency, needs an immediate needle decompression and follow-up chest tube. Okay, 2 more big ones to go. So acute decompensated heart failure. So think about flash pulmonary edema. So symptoms, short of breath with exertion, our PND, orthopnea, JVD, our weight gain, abdominal distension, fatigue and exercise intolerance, palpitations, increased heart rate, chest discomfort, cough, pink frothy sputum. On physical exam, think about edema, so pitting edema, rales and crackles, a murmur, decreased breath sounds if there's a pleural effusion present, JVD, abdominal distension. It can initially be very difficult to distinguish heart failure exacerbation from COPD exacerbation. These patients are going to be hypoxic and tachycardic and tachypenic. So as we kind of remember from cardiology, is heart failure is that group of kind of clinical signs and symptoms that results from changes in how the heart contracts, how our valves are behaving, our preload and afterload, as well as the heart rate. So that all results in kind of the inability of the heart to be able to meet the metabolic demands of the body. So if we kind of remember the differences between right and left-sided heart failure, so cor pulmonale, on left-sided, whether or not we have preserved ejection fraction, and then think about heart failure in a merge standpoint is, do we have acute or a chronic heart failure condition? And there are some non-cardiac causes that can be related to high output failure as well. So those patients with like extreme anemia, as well as thyroid toxicosis, which we talked about in our endocrine lecture. So as far as investigations for decompensated or acute exacerbation of heart failure, CBC, so you're looking for anemia, chest x-ray, you're looking for those wet lungs, pulmonary edema. Get a BNP, so we're going to see it greater than 100. Get your comprehensive metabolic panel, troponins, if they're presenting with chest pain and you're thinking MI, TSH for thyroid, EKG, really helpful to kind of identify any of the underlying conditions that could be driving the heart failure, left ventricular hypertrophy, left atrial abnormalities, MI, is there any arrhythmias present? An echo is going to be your gold standard here. You really want to have a look at what that left ventricle and ejection fraction is doing. Have a look at what the ventricle size is, what the wall motion is doing. Do we have an akinetic ventricle going on? What's going on with the valves? Any pericardial disease, as well as estimating that right atrial function, having a look at what our pressures are going to be as well. So the Swan-Ganz catheter is really important. So this is a good measurement. It's very similar to Artline measurements. It gives us measurements of the pulmonary artery pressure, pulmonary artery wedge pressure, central venous pressure, and cardiac output. So my patients, we put this in their central line, and it gave us really good instant information on any of the inotropes or pressors we put our patients on, so we could make titration adjustments as needed based on those measurements. So general treatment of acute heart failure, so again, our ABCs, like put your patient in an upright position because they feel like they're drowning because they do actually have wet lungs. Get them on oxygen. Consider BiPAP or CPAP. Again, we want to be able to drive out the fluid out of the alveoli and open up that airway. Throwing a good hefty dose of Lasix at them, cardiac monitor, monitoring their SATs, giving slight IV fluids. You have to be really careful with patients here, putting in a Foley catheter because, again, you're diuresing these patients. And then you may need vasodilator therapy, so pressors as well. And some patients may need inotropic therapy as well. So if you weren't familiar with what TKVO means, it's just a short form for to keep vein open, and that's generally what we will give IV fluid in case we need to access vessels very quickly. And specifically for acute heart failure, so we talked about the oxygen, giving them Lasix to pull that fluid off the lungs, nitrates, so venodilation and pain relief. You can also consider morphine. So morphine is not only a great pain reliever, but it also causes venodilation. Morphine also will kind of help with patient anxiety, decreases that work of breathing, and helps to reduce both the preload and the afterload. But we do have to be kind of cautious in patients with impending airway compromise because it could push us more towards intubation because of that respiratory depression. So often also are going to need to co-treat patients who have COPD exacerbation until a definitive diagnosis is made. So that should always be on our differential diagnosis. We may need to transfuse red cells in those patients that have high output failure from severe anemia. And then I like the LMNOP mnemonic, so Lasix, morphine, nitrates, oxygen, and positive pressure for acute treatment of acute heart failure. So our specific treatment, so first-line therapy, so our nitro and our Lasix. If we don't have good response to our first line, I hit them with another dose of Lasix. We can consider a nitro infusion, especially if we have a patient who also has angina or hypertensive, and we can titrate that. We talked about CPAP and BiPAP, really important there. If we have a patient with altered mental status or a loss of decreased level of consciousness, or a patient who has impending respiratory failure, those are the patients I'm going to think about intubating. If my systolic BP is less than 90, I'm going to start my inotropes, and so dobutamine is kind of the go-to. If they're not responding to the albutamine, I can consider giving a low-dose dopamine, but my go-to would probably be milrinone in addition to the dobutamine. And then if I've got pretty significant hypertension, I can consider starting nitropuricide. So inotropes used in patients with hypotension because that's the contractility. But it's also can be used as adjunct therapy in patients with pretty severe pulmonary edema without the hypotension that really is refractory to the initial treatment of Lasix and nitro. So inotropes are drugs that improve that contractility, therefore really improving the cardiac output as well as the systemic tissue perfusion. So when I have a patient with severe and refractory pulmonary edema, using ultrafiltration is also a really good method of fluid removal and may be required in patients with severe renal insufficiency. So in ICU, it wasn't really uncommon for us to initiate continuous dialysis. So most of the time when we think about dialysis, patients will go and have, a dialysis treatment, 3 to 4 times a week. My patients were on continuous dialysis, so it would continuously, remove unnecessary fluids for those patients that just weren't getting kidney perfusion. So that is definitely another option. The other thing that we can certainly consider in CCU, ICU is the use of an intra-aortic balloon pump, as well as an LVAD to provide assistance of those patients in cardiogenic shock. So those patients, if you were working in the ED as a PA, would certainly be consulting cardiology, and they would be kind of taking control of those particular patients. So when we're talking about acute heart failure, we're really talking about acute pulmonary edema, which is that accumulation of fluid within the alveoli and the interstitium from elevated pulmonary venous pressures. And that's generally due secondary to that cardiac dysfunction, which ultimately causes that gas exchange to not occur and then leads them to that respiratory failure. So pulmonary edema, in addition to acute heart failure, can be caused by excessive fluid administration. So, not uncommon for us to be resuscitating patients and throwing 3 liters of fluid at them, only for a lot of it to land in their lungs, in which case I just diurese them. So keep that in mind when you're administering fluids. You really need to have a good look at their inputs and outputs and regularly listen to their lungs. And you can quickly identify, I kind of was zealous with my fluids. I need to get rid of some of that. And then pulmonary venous outflow obstruction if we have that left ventricular failure, rarely can be caused by re-expansion pulmonary edema. So that's a case where they have flash pulmonary edema. So physical exam, so all those things, wet lungs. So they'll be tripoding rails, they'll sound like wet lungs, they'll be diaphoretic, extreme anxiety because they can't get their breath, tachycardic, could have significant hypertension, hypoxia, and certainly chest discomfort. So we kind of talked about all of those treatment modalities, but BiPAP and Lasix are going to be your good friends here. So our key points of acute heart failure. So we know it occurs when the pump failure is severe enough to cause increased pulmonary pressures, which then results in fluid retention in the lungs. If possible, really identify and try and correct what's ever driving the heart failure. They will definitely present in respiratory distress when they're in flash pulmonary edema. Chest X-ray is has very classic characteristics that we'll see, so like the bat winging, curly bee lines, etc. Patients presenting with shortness of breath whose clinical assessment and chest X-ray suggest it, but may not clearly be diagnostic of heart failure. Really measuring that BNP is going to be very helpful in ruling in or out congestive heart failure, and management of the patients requires stabilization of our ABCs, diuretics, potentially vasodilation therapy, and then think of our positive non-invasive pressure, CPAP, BiPAP. And then those patients that go on to cardiogenic shock really need those inotropes and really ICU care at that point. So in our last respiratory distress, shortness of breath killer is going to be our cardiac tamponade, which can also be in our chest pain killer. So pericardial effusion. So we know it has that significant pressure on the heart, basically impeding the ability of the heart to fill because of the pressure of the fluid in that pericardial sac. That leads to a decreased cardiac output and cardiogenic shock. So what's important to know here is it's actually the rate of the speed, like how quickly that fluid or blood is accumulating within that pericardial sac is actually more important than the actual volume. And I'll say that up to a certain point. So when we have a patient who has rapid accumulation of that fluid, that tamponade, even with a minimal amount of fluid, can be more significant than a fairly large amount of fluid that's kind of accumulated over a period of time, because your heart has the ability to kind of adapt to that slow accumulation of fluid. So it's much more compliant than a rapid. So if you can imagine like a trauma patient or my patients that have had surgery, that maybe a vessel has been nicked and that blood is just pumping into that pericardial space, that heart does not have time to be compliant to that fluid buildup. So they are going to be tamponading and shocking really, really quickly versus a patient that may have, say cancer, and that fluid is like slowly accumulating over time. Your heart has the ability to kind of be compliant as well as the sac. So that is going to be a really important thing here. So etiology, so pericarditis is often associated with tamponade. So our trauma patients, cardiac surgery, and cancer are all etiology here. So our physical exam findings. So remember Beck's triad. So you have a patient who's got distant or muffled heart sounds, JVD, hypotensive. But they also will be short of breath, fatigue. They could be having peripheral edema, tachycardic, tachypenic. They'll be shocky, cyanosis, pulsus paradoxus. So that is a 10 millimeter of mercury decrease in systolic with inspiration. Our picture of tamponade. So I always like to have this image in my mind while I am envisioning what it would sound like. So if you think about putting your stethoscope to a patient's chest who has fluid surrounding the heart, it is going to be a muffled heart sound. So you will not be able to hear it. So when we talk about distance or muffled, you're having to listen to those valves through fluid. So it definitely dampens on what we're able to hear. And then our diagnostic tests. So what are we seeing on chest x-ray? So you're going to have a widened mediastinum and an enlarged heart. Echo, so you're looking for that pericardial effusion. So that's going to be kind of our gold standard there. Diastolic collapse of the chamber, so they're just not able to pump. On EKG, look for low voltage QRS complexes, and then electrical alternans. So that is an alternating, one's high, one's low. Look for those for sure. The other thing, with the bedside ultrasound, you're immediately having that ability to see what's going on with those ventricles as well as fluid accumulation. And then treatment, so our pericardiocentesis, cardiogenic shock, it is all about fluid resuscitation. So you have to be really, really careful so you're not giving the same kind of fluids in a cardiogenic shock patient that you would with any other shock outputs. Pressor support is going to be really important here as well. Consider surgical creation of a pericardial window if your pericardial centesis is not working. So in the emerge department, like you're calling cardiology or a cardiac surgeon to do this. If you do end up working in CCU, you're gonna get good at this. And then, so this is how I did it. So either you can use ultrasound guided. I kind of used the combo. So you're actually attaching your needle that's going to be connected to an EKG, and you're slowly introducing the needle. As soon as you see a jump in your ST, you have an ST elevation. If you tapped the heart, to pull back just slightly and you're in the perfect space. Using ultrasound, again, ultrasound guided needle pericardiocentesis. And that is shortness of breath, respiratory distress.